Okay, so now we're going to be looking at the shoulder joint. So we're going to continue on from looking at the shoulder girdle and actually talk about the shoulder joint, the movements and the muscles, and all of the bony landmarks that are in the region of the joint. So just to review a little bit, the girdle versus the joint. So again, remember the shoulder girdle is made up of the acromioclavicular joint, which is the articulation between the scapula and the clavicle, the scapulothoracic joint, which is where the scapula glides along the thorax, the rib cage, and the sternoclavicular joint, where the sternum articulates with the clavicle. So now what we're going to be focusing on is the glenohumeral joint, which is the articulation between the scapula and the humerus. So we're focusing on right here. So the shoulder girdle kind of encompasses this entire region here, following kind of along the sternum, clavicle, scapula, and then obviously that articulation with the rib cage. But now we're going to be looking at the shoulder joint itself. Okay, so the shoulder girdle versus the joint. So there's some rules that you could kind of remember in kind of looking at maybe some of the differences. So the shoulder joint and girdle work together to carry out upper extremity tasks. And we kind of talked about this a little bit. And you'll learn even more depth with this when you get into like your biomechanics class, because we'll be talking about how much the shoulder girdle actually has to move and what movements occur at those joints in order for you to get kind of full motion and full function out of your upper extremity. From the standpoint of just strictly looking at anatomy, there are some rules that you could kind of separate to kind of know and understand anatomically the differences between. So the shoulder girdle rules, if you will. One, the muscles have to originate on the axial skeleton. Okay, so in other words, they have to originate on, again, we typically look at them originating on the spine. That's the reason why we talked about the spine as a part of the shoulder girdle, because that's where a lot of the muscles will originate on. They have to insert on the clavicle and or the scapula, and they have to move the scapula. So these muscles will not attached to the upper arm of the humerus, okay? They have to originate on the axial skeleton and insert on the clavicle or scapula and move the scapula. Then there's the shoulder joint rules. Now, there are actually two exceptions to the shoulder joint rules, which you will see. So these are the general shoulder joint rules. There's going to be two exceptions to these rules, and we'll see them later on. The muscles have to originate on the clavicle and or the scapula. They have to insert on the humerus, and they have to move the humerus. Okay? Now, again, there's going to be two exceptions to this rule that we'll encounter as we're going throughout. So pay close attention to that as we kind of go along. But these are the shoulder joint rules. So to differentiate the muscles of the shoulder girdle and what they do versus the muscles of the shoulder joint. Again, it's important to know all of your scapular landmarks. Okay, so if we look here at the scapula and we look at these various landmarks, so all these various landmarks are to be noted as they are on the scapula. Then you have your landmarks on the humerus. Okay, so you have your humerus landmarks. You have the head of the humerus. You have the greater tubercle. You have the lesser tubercle. Okay, so note the location of all of those. Again, you can see them on the various pictures. You have the deltoid tuberosity. And you have the intertubercular or bicipital groove. Okay, now again, when you're looking at all these pictures, make sure you're kind of aware of what it is that you're looking at when you're examining these pictures. So for instance, you know, you're looking here at an anterior view. Here you're looking at a posterior view. Okay, so you could kind of note different landmarks when you're looking anteriorly versus posteriorly. Now, we're kind of primarily focused on, obviously, the proximal region. This is the humerus, the bone in your upper arm. We're primarily concerned with this upper region here, I guess encompassing the deltoid tuberosity as well. Okay, but you can also tell whether you're looking at the anterior surface by looking at the distal landmarks. Now, you're not going to be responsible for these distal landmarks yet, but you could kind of tell. But one of the ways to tell whether you're looking at the anterior surface of the humerus, and you want to be doing this when you're looking at the models, is look for that lesser tubercle and the intertubercular groove. Then you know you're looking at the anterior surface. That will also help you in noting whether you're looking at a right or a left. Here you get a little closer view up here at this illustration. Okay, so looking at the shoulder joint, so the shoulder joint itself is a ball and socket joint. You're going to have 3 degrees freedom of motion with it. So it will move in all 3 planes. You'll move in the sagittal, the frontal, and the transverse plane. You notice just the overall structure of it. So it's a ball and socket joint, but you'll hear the term golf ball on a tee. So most of the stability to this joint is going to be maintained by the soft tissue, because you can tell just by looking at it. So here's the glenoid cavity. So this is the concave surface, if you will. This is your convex surface. If you look at the size of the humeral head and the glenoid cavity, there's not a lot of just regular stability there. In other words, if you just had these 2 bones together, the joint wouldn't be very stable. So it's really the soft tissue that kind of provides much of the stability to the glenohumeral joint. However, by virtue of its structure, it gives you much more freedom of motion, which obviously we need in kind of placing the arm to be able to move our upper extremity in all those various planes. So it's a ball and socket joint. You see the humeral head and glenoid fossa pictured in the illustration. Another thing that is a primary support, so we had mentioned the soft tissue at the glenohumeral joint. So here you're actually looking at this is the glenoid fossa. There is a cartilage ring that kind of lines the outside surface called the glenoid labrum. So you can see all the different tendons and ligaments that also help to support, but this glenoid labrum kind of deepens the cavity a little bit. So it's a little bit of a ring of cartilage, soft tissue, that helps with the stability in keeping the humeral head inside that region. And this is a structure that can be torn and worn down, or could suffer acute tears. And those are the individuals that you will find that many times will end up having instability in their shoulder. So again, as sports medicine, physical therapy majors, that's something that would be a pathology in the shoulder that you would encounter, as a torn glenoid labrum. So again, your other soft tissue support. So you have the joint capsule, which is just it's basically the big ligamentous tissue, and then within that joint capsule, you have the thickenings in the joint capsule, which are the various ligaments that support the glenohumeral joint. So you can see the joint capsule in the picture, and then the kind of thickened parts of it are basically the various ligaments. You have the superior glenohumeral, middle glenohumeral, and inferior glenohumeral ligaments, and those ligaments will provide support to the joint. So just some brief stuff. Again, I know that, again, we're all looking down the road at clinically evaluating the shoulder and understanding what all this anatomy means. Some common issues to have with the shoulder joint are instability problems. And these instability issues can lead to a lot of issues. So, we obviously have a great deal of range of motion in a normal, healthy shoulder. However, again, issues can arise where the shoulder becomes unstable and could cause problems, most notably impingement of the rotator cuff, where the rotator cuff, as you'll see anatomically, doesn't have a whole lot of room to move in the region where it's at. And if a person has an unstable shoulder, they can actually pinch those tendons and cause some pain and maybe even some tearing take place, and just subluxations and dislocations. So a subluxation is when the glenohumeral joint, when it kind of, if you will, comes out of place but goes back in, or doesn't completely come out. And a dislocation is when there's complete incongruency between the joint surfaces. Now again, we have a great amount of mobility at the shoulder. However, the price of mobility is reduced stability, meaning that there's always a give and take. The more mobile a joint is, the less stable it tends to be. So that's an important point to note, okay? If a joint is more stable, it's less mobile. So just to kind of show a comparison, so both the shoulder joint and the hip joint are both ball and socket joints. However, if you look at a hip joint, which we haven't done yet, you'll see that the hip joint, while it's a ball and socket joint and still does allow motion in all the planes, the structure of the hip joint is much more stable. So you don't have quite the range of motion at the hip that you do at the shoulder joint. And there's a reason for that, is because your hips have to be weight bearing and they have to support you in walking and in gait, jumping, landing. So if the hip joint had the same amount of mobility with reduced stability as you have with the shoulder joint, you'd have a lot of problems with dislocating your hip because it wouldn't be able to withstand those forces. So again, wide range of motion, the shoulder joint requires a significant amount of laxity. And again, the shoulder has a very different function, obviously, than at the hip, and has to and is meant to withstand different types of forces. So our motions at the glenohumeral joint. So again, flexion is when you move the humerus anteriorly. Extension is both a return from flexion or moving the humerus posteriorly. Okay. So again, when extension is even still. So if your shoulder is flexed and you just bring it down, you're still extending your shoulder. Some people do refer to this as, then hyperextension. So you will hear that sometimes, but just know that the extension is movement of the humerus posteriorly. So as we're going through all these, be thinking about what plane that these motions occur in. Abduction and adduction. Abduction, upward or lateral movement away from the body. Adduction, downward movement toward the body, or a return from abduction. Again, be thinking of your planes of motion as we're doing this. Okay, some different motions. Now, these are kind of, if you will, they're a combination of movements. So when you look at horizontal adduction, that's movement of the humerus horizontally towards and across the chest. So, your arm has to be in a degree of it has to be elevated in order to do this. And then horizontal abduction is movement of the humerus horizontally away from the chest. And then external and internal rotation. External rotation is, or also known as lateral rotation, is rotary movement of the humerus away from the midline. And internal rotation is rotary movement of the humerus medially towards the midline. Again, be thinking about your plane of motion with this as well. So now we get into the muscles, and again, I might seem to move through some of these quick, because we're really just looking at the muscles, where they originate, where they insert, and kind of what they do. Okay, and again, also, throughout this, be kind of looking at the photos as far as, so again, much like the pictures I showed in the previous, you'll see the actual full muscle on one side. On the other side, you'll see kind of the origins and insertions kind of shaded. So, here's the full deltoid. Here's they're showing you what the origin insertion. So basically the muscle would be right here. So, pay mind to these pictures, and they're also showing you the movements that take place. So this might be a part in the lectures. I don't know if I mentioned this in the previous one or not, where you may want to pause and just look at the pictures and kind of take in the information. Maybe you'll be filling out the charts that I gave you in class as well. So the origins: lateral clavicle, acromion, and spine of the scapula. It inserts on the deltoid tuberosity of the humerus. So there's kind of another thing, the anatomical landmarks are significant for a reason. So, the deltoid tuberosity, we showed that as a relevant anatomical landmark. So kind of note that. And then the action is all portions perform abduction of the humerus. The anterior portion performs more glenohumeral flexion. So again, there are portions of the deltoid. The posterior portion performs glenohumeral extension. So further looking at the glenohumeral muscles, we have the pectoralis major. Again, there's your origin, clavicle, the ribs 1 through 6 in the sternum. The insertions, the bicipital groove or the intertubercular groove. The action is internal rotation and adduction of the humerus. And if you remember, now remember something we said earlier on about the rules? Well, here's one of your exception to the shoulder joint rules. So now here's a question for you. Why is this an exception to the shoulder joint rules? Why do you think? Think about it for a second. So if you remember, the shoulder joint rules was it has to originate on the scapula or clavicle. Well, look at where it originates. It actually originates on the axial skeleton because it originates on the ribs and the sternum. So that goes, it's a contradictory to the shoulder joint rule. So this is one of your exceptions to the rules of the shoulder joint. So it is a shoulder joint muscle, but it does not follow the shoulder joint rules that we discussed earlier. Okay, here we have the latissimus dorsi. Latissimus dorsi, very large muscle. Its origin, posterior ilium sacrum, and then the spinous processes of T6 through L5. The inserts on the medial side of the bicipital groove. So the lat actually kind of wraps around. So it's on the posterior surface of the body, but as it comes up, it actually wraps around to the front of the humerus. Okay, so it takes a pretty interesting path. It actually wraps around to the front. You can see here where they're kind of showing that. And its action is extension and adduction of the humerus along with internal rotation. And what do we have again? We have the other exception to the shoulder joint rules because it does not have an origin. It actually has no origin at all on the scapula or the clavicle. Its origin is all on the or originates on the axial spine and also on the ilium, the pelvis as well. Okay, the teres major, also known as some people hear the teres major, also called the little lat. Okay, they refer to the teres major as the little lat. The origin's the inferior lateral border of the scapula. It inserts on the medial side of the bicipital groove, so near the insertion of the lat. And it extends, adducts, and internally rotates the humerus. So it basically helps the lat perform the actions that it does. Now, clinically, for some movement things and stuff like that, the teres major has a little bit of a different impact because of its origin, if you will, on the scapula. So the teres major follows the shoulder joint rules. It originates on the scapula, so that's what makes it different. But if you look at the way it runs and what it does, it's basically, as we said, you'll hear people call it the little lat. The coracobrachialis. So again, I always say there's something to a name. Sometimes when you look at the name of the muscle, again, you got to find different ways to kind of remember things. Well, this is a really good example to the name meaning something. So its origin is the coracoid process. It inserts on the medial humerus. So coracobrachialis, okay, the brachial region is the upper arm. And it horizontally adducts and flexes the humerus. So here's your rotator cuff muscles. So when we look at the rotator cuff muscles, okay, you start with the supraspinatus. Okay, it attaches to the greater tubercle from above, so it produces abduction. Okay, so the supraspinatus works to abduct the humerus. The infraspinatus attaches to the greater tubercle posteriorly, and that does external rotation. The teres minor also attaches to the greater tubercle posteriorly and also does external rotation. And then the subscapularis attaches to the lesser tubercle anteriorly and does internal rotation. So if you look at this picture, you can kind of see. So if you look, let me pull up the pointer. So here's your subscapularis. I'll do them in order so it makes a little more sense. The supraspinatus right up in here. Okay. And we're going to look at these all individually as well on the upcoming slides. Here is your infraspinatus down here, your teres minor, and then you have the subscapularis. Okay. Now they're also called the sits muscles for the reason that they have the mnemonic sits. Okay. So they do those motions, and in addition to that, they provide stability to the shoulder joint. So your rotator cuff is a pretty active muscle group all the time because it's also kind of the active restraint. If you kind of notice the way they all kind of wrap around and envelop the humerus, they kind of show some stability to that joint. So the supraspinatus. Okay, you can see the supraspinatus, what it looks like by itself. So again, sometimes it might be a little easier to see it on its own. Supraspinous fossa, greater tubercle of the humerus, and again, it abducts the humerus. Okay, it's not uncommon to see some sources say that it contributes to external rotation, but for the most part, if you look the way it kind of rides along the top of the humeral head, the contributions to external rotation are likely limited. So we're just going to go with abduction of the humerus. The infraspinatus. So again, something to a name. So the supraspinatus, well, it originated on the superior aspect of the spinous scapula, or the supraspinous fossa. The infraspinatus comes from the infraspinous fossa. So the origin of the infraspinous fossa inserts on the greater tubercle of the humerus, and it does external rotation. It also will contribute a little bit to horizontal abduction and extension of the humerus. Teres minor, upper lateral border of the scapula, the greater tubercle of the humerus, and again, much like the infraspinatus, external rotation, horizontal abduction, and extension. And again, you can kind of see the origin insertion and what it looks like relative to where it would be in regards to the other rotator cuff muscles. Then the subscapularis. So again, now you're looking at, again, a muscle now on the anterior surface of the scapula. So it originates on the subscapular fossa, inserts on the lesser tubercle of the humerus, and does internal rotation, adduction, and extension of the humerus. And again, here's another perspective. We looked at this picture earlier, but you could kind of see, again, how those tendons, so that's why I say, in addition to the movements they do, they provide a significant amount of stability to the glenohumeral joint because of how they approximate with the other more passive structures. And again, we also mentioned, again, the mnemonic sits. So sits for supraspinatus, infraspinatus, teres minor, and subscapularis. Here's another great illustration. So this one's a little bit more, kind of more realistic looking. You can kind of see. So here's your supraspinatus. So this is a posterior view. This is an anterior view. So you can see the supraspinatus. Here you see your infraspinatus. You see your teres minor. Okay, so you can kind of see the orientation, how one sits how the teres minor sits a little lower. The infraspinatus kind of comes up a little higher. So like here's your supraspinatus tendon, here's your infraspinatus, here's your teres minor. Now your subscap, because it comes around on the lesser tubercle and it's on the anterior surface, so you notice you can't see the subscap because it's on the anterior surface. The subscapular fossa is on the anterior surface of the scapula. You could see how that orientation is different. So again, whether you're looking at a model or a picture, again, start with knowing, am I looking at a posterior view, an anterior view, a lateral view, and then start to go. Okay, I think that's the mistake even when looking at models a lot of students make, is they just, they'll kind of look at a model or pick it up and they don't orientate themselves to what it is they're looking at. Okay, make sure you do that before you start, picking out your landmarks and looking at them. Okay, some other glenohumeral muscles. Now, these are muscles that they cross the shoulder joint. They don't tend to have as much big action at the shoulder joint. Both of these function more at the elbow, but because they do cross the shoulder joint, they do contribute slightly to some motion, so we are going to cover them here. So the biceps brachii does assist in glenohumeral flexion. Okay, so the big muscle in the front of your humerus or the anterior surface, the biceps brachii, does assist with glenohumeral. It's a weak flexor. Now, it doesn't provide a lot to it, but it does assist with it because it does the tendon, the long head does, cross that joint. So you have two heads, the long head, the supraglenoid tubercle through the intertubercular groove or the bicipital groove, the short head, the coracoid process. So even the short head, again, is going to contribute to that because of its attachment in the coracoid process of the scapula. So the primary action where it functions a little, better or provides more strength to is to elbow flexion. If we go to the tricep, so the tricep assists in glenohumeral extension. Now, there are three heads. So the reason why it's called the tricep is because there's three heads. The bicep has two heads. It's called the bicep. However, only one crosses the shoulder joint, the long head origin. So the long head is on the infraglenoid tubercle. The other heads don't cross the shoulder joint because they're on the humerus. And again, the primary action there is elbow extension, but they do assist with shoulder extension because of that long head. So here's a look at your surface anatomy. Again, you want to familiarize yourself with as many illustrations as you can to kind of help things. You can kind of see where all these different muscles lie on an individual, so it can kind of give you an idea. Again, we don't palpate anybody really yet in class or really work on that, but that's something that's going to be coming. So the more familiar you are with that surface anatomy and kind of correlating that with your models and the illustrations that I show you, the easier that will be. So when you get into your more advanced, even more advanced functional anatomy classes in your graduate studies, this is going to become very important. So again, we also like to kind of look at it just strictly from a movement standpoint. So glenohumeral abduction, the agonist to glenohumeral abduction, the deltoid, and the supraspinatus. And you can see those muscles, the illustrations again here as well. Glenohumeral adduction, you have the latissimus dorsi, the teres major, and the lower pectoralis major. So the lower portion of the pec major will contribute to horizontal adduction. Glenohumeral extension, teres major, latissimus dorsi. And again, don't memorize lists of movements. So as I'm going through these, look at the muscles, think about why they would produce that motion. Look at the course that they take. Okay, so be looking at these pictures, and again, you might want to pause as I'm going through some things because some of the illustrations I might move a little bit faster. So pause for a second. Look at the way the muscles kind of ride along their path because that gives you then an idea. So understand why they produce that motion. Okay, don't just try to think, okay, I'm going to memorize this list. These are the muscles that do this, because it's a lot easier to get mixed up in that fashion. Look at the muscle. So, just as an example, looking here, you can see the way these muscles course. Remember, the insertion is more on the anterior side of the humerus. Okay, So if you think of that line of pull, even on yourself, like do the motion and even feel, I would encourage you, do some palpation even on yourself to be able to feel what these muscles are like and feel the motions. Again, that's going to help you understand things more. Okay, glenohumeral flexion, the anterior deltoid, and the upper pec major. So the upper pec, so the pec, if you look at it, actually has kind of a unique sort of structure to it. And actually, in some functional anatomy, they look at two different points of the pec. They look at the clavicular portion versus the sternal portion. So the clavicular portion of the pec will actually contribute to shoulder flexion. You could feel that on yourself. If you kind of put your hand on the upper part of your pec and flex your shoulder, you can kind of feel that the muscle contracting and having action when you go and do that. Glenohumeral internal rotation, the latissimus dorsi, the teres major, the subscapularis. So the subscapularis is the only sits muscle that does internal rotation, and the pectoralis major. Again, they all attach anteromedially on the humerus. This is why I keep encouraging you, again, look at that course of action and how it would create. So again, look beyond just knowing, okay, the lat does internal rotation. Well, why does the lat do internal rotation? Look at the way it runs. Look at its orientation from its origin to insertion. Okay, external rotation, your agonist, the infraspinatus and teres minor. And again, both are going to attach posteriorly on the greater tubercle. And then your glenohumeral horizontal abduction. So your agonist, the posterior deltoid, middle deltoid, the infraspinatus, and the teres minor. The reason why the middle deltoid is going to be included in this is just to really get yourself in position. The middle deltoid really has to participate in kind of getting that initial position down. And then horizontal adduction. Again, your agonist, the anterior deltoid, the pectoralis major, and the coracobrachialis. So that actually wraps up the shoulder joint. Now, those of you that have had me in other classes, you know that I'm usually pretty intentional with the learning outcomes. Really, the learning outcomes for all of these different, anatomical regions are going to be all the same. You have to know the origin, insertion, action of all of the muscles. You have to know all of the bones that make up the region along with the bony landmarks, okay? So, and they were all kind of illustrated in various ways throughout the conversation.